Heather, do you want to go ahead and take it off? In the interest of time, let's just get this going. This is going to be I think, very rich discussion. So I'm happy to turn it over to Dr. Heather Young at the University of California, Davis.
Thank you, Dr. Kaiser. Hello, and welcome to Session 6, Stakeholder Perspectives on the Discussion and Priorities for the Path Forward. I'm Heather Young, a professor and gerontological nurse scientist at the Betty Irene Moore School of Nursing at the University of California, Davis, and I have no conflicts to report. The past day and a half have been filled with stimulating ideas and perspectives, highlighting the complexity and the relevance of the topics of access to care and person-centeredness. Yesterday, Dr. Fortney and others discussed the importance of listening to veterans about access and to connecting outcomes important to them to relevant clinical outcomes. It's my honor to moderate the last panel of the workshop with discussants representing veteran, clinician, systems, and regulatory perspectives. Our 8 distinguished panelists today include Donald Overton of the Blinded Veterans Association, Commander Renee Campos of the Veterans Wounded Warrior Care and Military Officers Association of America, Dr. Pamela LeDeaux, VA New Jersey Healthcare System, Tia Archambault of the U.S. Department of Veterans Affairs, Dr. Peter Choi of the U.S. Department of Veterans Affairs, Alexis MacDonald of the House Veterans Affairs Committee, and Emily Blair of the Senate Committee on Veterans Affairs. I'm going to ask each panelist to introduce themselves and spend about 5 minutes each talking about their principal priority for ensuring veterans' access to healthcare services. And after their initial remarks, there'll be approximately 40 minutes for our group discussion, and we're eager to see your questions as well. So if I could ask Donald to begin.
Absolutely. Thank you so much, ma'am. Again, my name is Donald Overton. I am currently serving as the Executive Director of the Blinded Veterans Association. BVA is a congressionally chartered organization celebrating its 75th year, exclusively advocating on behalf of our nation's blind and visually impaired veterans. I am a combat blinded veteran myself. I served in the United States Army with the 82nd Airborne Division and was blinded back during the first Gulf War operations Desert Shield and Desert Storm. So I have been a military and veterans advocate for approximately 30 years, and I'm also a consumer of VA services. I believe the critical importance from our organizational perspective, as well as myself as a stakeholder, is looking at making sure that we're looking at the accessibility aspects of access to care. As we continue to see modernization and new approaches towards service delivery, it becomes critically important to make sure that we don't overlook those cohorts of individuals that are requiring unique approaches. So whether we're dealing, with vision loss or hearing loss, or folks with mobility concerns, it's making sure that as we deploy these new platforms and these new systems, we're remembering to take into consideration what the implications are going to be, so that we don't ever leave any groups of veterans outside of those areas. So as we approach the 30th anniversary of the Americans with Disabilities Act, we continue to face challenges, whether those be accessing, kiosks within these systems or any of the other modern approaches. We continue to deal with 504 and 508 related compliance issues. And so that's really where we're focused on, is looking at, not just the potential physical barriers, but also, the technological barriers, and making sure that, all of those individuals that we have the honor and privilege of representing are able to access equal care on an equal playing field. And so I'll leave it at that for now. So thank you.
Thank you, Donald. Renee?
Good morning, everybody. And thanks to the National Academies and VA for this workshop. It has been a day and a half of great information, and it's a great opportunity to be here today. Again, my name is Renee Campos. I'm the Senior Director of Government Relations for Veterans and Wounded Warrior Care at the Military Officers Association of America, or MOA as we call it. And our primary core mission, we are both a military and veteran service organization, and our core mission is to advocate on behalf of our members, but also all uniformed service members. That includes Coast Guard, NOAA, and Public Health Service. And that's officer enlisted, Guard and Reserve, veterans and their families, caregivers, and surviving family members. Now, I've had the privilege of being at MOA for over 14 years. I'm a 30-year Navy veteran, and I have had the privilege of using VA healthcare, both on active duty and then now as a veteran. And so we are, the advocacy work that we do is really centered around protecting service members, veterans, and their families, protecting their service earned benefits and quality of life programs. But we don't do it alone. We work with other colleagues here, like with Donald's organization and others in the Military Coalition, which is a consortium of a number of organizations that represent over 5 million folks. And our primary principal priority focus at MOA in the area of veterans health is really making sure that veterans have access to quality health care. And we also are watching really closely how, and working with Congress and also other organizations and stakeholders with the implementation of the Mission Act, which was discussed earlier. But we can't talk about, in our organization, when we think of veterans access, you can't separate that access from VHA's workforce. And that is directly tied, veterans access is directly tied to that workforce and that veterans relationship with their provider and care team, as well as that veterans relationship with the broader healthcare system. So when we look at our healthcare priorities and veterans access, we do focus quite heavily on VA's workforce. And because VA's workforce is its core identity, it's how VA has earned its reputation as a leader in in delivering quality healthcare. And I was struck last week by a comment that Chairman Moran of the Senate Veterans Affairs Committee had when he held a hearing on workforce issues. And he said, how VA treats staff is an indication of how well VA will treat its veterans. And that really rings true with me. Now, a lot of the issues that center around workforce have, been and challenges have been with high employee vacancies and turnover. And these were challenges and systemic issues prior to the pandemic. And as many are aware, there were, there's been a lot of, and certainly reported through the VA, OIG and GAO of severe occupational shortages. And so these are very important issues and have, have really impacted VA or veterans' access to healthcare. So when VA started, as we entered this crisis, we have seen them lean into the challenges, establishing a rapid hiring process and establishing a staffing command cell to manage, deployments of staff, but also hire folks rather quickly. And so they've onboarded over 20,000 employees, which is really impressive. And VA said between 85 and 90% of these employees are permanent employees. So we're looking forward to seeing how VA, as we come out of the pandemic, will be able to apply some of those rapid hiring and how they've streamlined their HR system in order to be able to attack some of the systemic underlying problems they had going into the pandemic. I'd also just indicate that, access to quality care, again, is so important. And if we don't address the workforce issues, we're going to continue to have problems for veterans being able to get that care and set those appointments. But it also will impact VA's reputation. And if we think about it, VA's been under a lot of constant change for almost 2 decades. Stabilizing and simplifying and building predictability into the system is really, really important, because you can think toll that it's taken already on the workforce with this constant change. So if we don't address the workforce issues, this will, and all these reforms and all the stresses we keep putting on the system, we're just going to create a domino effect and will ultimately impact the veterans' healthcare outcomes and also affect VA's reputation as a quality health provider. And one other thing that is really important to remember about access is that access is also directly tied to communication. That communication the veteran has with the provider, and that relationship is very important. And it's important both pre and post visit, and how well the provider in the system helps the veteran navigate through the VA is also critical. VA has had an age-old problem of communicating with veterans, and so the pandemic has made it more challenging. What veterans don't want to see is what happened to me, where during the pandemic, as I had been trying pre-pandemic and to set up a healthcare visit with my primary care manager, I find out in that process that my provider of 16 years had retired last year and nobody notified me. So you don't want to find those things out, during a pandemic in general, but now I had a great visit, and it was a virtual telephonic, and I enjoyed it. I liked my provider, but I didn't get the sense that she had a lot of confidence in the system either, of how that care in the community that I was going to do follow-on care, how that was going to work, and if it would things would happen because of all the changes with the Mission Act. She wasn't sure how long it would take me to be able to follow on. But what veterans do want is they expect a dialogue and communicate with their provider. They want a care team and a provider that knows the system and how it works and helps guide them through the process. We don't want to be passed off to someone. We want to feel valued, and we want to feel that that there's indication in the system that the system cares about us, and the providers we want as a care team. I think the earlier panels talked about that we do want to feel value because we do see it as our system. And finally, that's what the Mission Act is all about, improving veterans' access to care. And then, of course, that strengthening the veteran and provider relationship. So we want, to improve that navigation, which is very important to veterans because this is a very complex system. So with that, I'll turn it over to my next colleague. Thank you.
Thank you, Renee, very much. Pamela.
Good morning, and I really do appreciate this opportunity to share my perspective. I have thoroughly enjoyed the speakers in the workshop so far, and I've actually gotten great reassurance that some of my thoughts are also the thoughts of the speakers, and those issues and subjects around access that I struggle with and worry about were all presented here. So I don't have new information, but I share my perspective. I am the Chief of Staff at the New Jersey VA Medical Center, which is part of VISN 2. And so our medical center serves New Jersey, and we have 2 major medical centers and 10 community-based clinics. And I spend, in my clinical leadership role, quite a bit of time and energy and effort on veterans' access to care because it is extremely important, as we all are aware. And personally, based on my own experience and observations, I choose to define access to care very broadly. And that broad definition for me would be any and everything within our healthcare system that facilitates our patients' ability to get the quality care that they desire and need would be what I consider access to care. And so that means that there are multiple access points and in turn, multiple opportunities for us to impact access for our patients positively. And so because of the way I view access so broadly, I think we need to operationalize a very expanded approach to access. And it should be patient-centered and driven by the values of our patients. So we currently take a pretty narrow approach to access to care that's system-driven and focuses quite a lot on wait times for appointments. And I don't think that's a surprise to anyone. And I think we do need to transition and have a different paradigm for access so that we can better meet the healthcare needs of the patients that we serve. So I, in my mind, look at access in three broad categories. And this is in no way comprehensive of access, but in my mind, I think of patient experience, which I think is hugely important, transitions of care, which sometimes can be left out of being important in access. We focus on an appointment being obtained timely, which is important, but then what about the transitions of care after the patient has entered the healthcare system? And then the third category is whole health. So first, I just want to mention a few things in each of those categories. For patient experience, that certainly would involve the perception that our patients have of the care that they receive and their access to it. But I view within patient experience the category of customer service, which I don't necessarily like that term, but for lack of a better term, how do we treat our patients when they access us? Because I really think that the way we treat patients and the experience that they have in our clinics and in our facilities has a direct impact on their future access and their thoughts about access to healthcare. So we need to make sure that the way we treat our patients is patient-centered and that it's compassionate care and listening care so that we can hear what their values are. Also, the physical experience that veterans have when they come to our facilities is important. I'm a huge proponent of a healing environment because I think that there is evidence that the environment of your healthcare impacts your health and well-being and your healing. And I also think that that includes an impact on whether you enjoy your access and whether you will continue to access healthcare facilities. So I think a healing environment's important, and simple things like our overcrowding of some of our clinic areas, long waits to be seen, those can be discouraging experiences that don't invite returns as might be necessary. And then also the non-face-to-face types of access modes, I'll just mention the telephone. If our patients want to speak with someone, it's so important that they're not waiting for so long that they feel they have to hang up and call back another time, or that they just don't get a pickup on the phone for a long time. So I think those types of access really do have to be included in patient experience. We have a secure messaging system in the VA, which has expanded access. And we also, other speakers spoke very well of our virtual care opportunities. I think that in the VA system, we really do have a jump on what COVID brought to us, which is we really have to explore virtual modalities of care. And then the experience that our patients have when they come really does need to be consistent so that their expectations are met consistently and that we're reliable in what we offer in our services. And I think, across VA, we all recognize that there should be some element of standardization of the experience that they have in our medical centers. So the second bucket that I mentioned was transitions of care. And once a veteran gets an appointment at the time that they want it, I think that then what are their further needs? And we need to pay attention to transitioning them to other parts of care just as closely as we paid to getting them into that first appointment. And so if they have referrals or they need diagnostics or therapeutics, we really have to carefully care coordinate those steps and help our patients through systems that are often quite complicated and confusing. And so coordinating care, doing care management, navigating through complexities is part of access to care, of course. And then the third large category that I want to mention is whole health. And I think that whole health really offers us a frame for access if we really change the way we think about it. And for those of you that aren't familiar, I know many of you are, whole health is VHA's patient-centered, holistic, transformational approach to healthcare that seeks to discover what matters most to our veterans and then approach their healthcare from that vantage point. And so veterans' preferences and feelings and priorities are important in whole health. And I was really happy to hear that the roundtable that took place earlier this year, it said that emphasis on patients' beliefs and feelings was a top priority, because I do think that it is. But if we do take a whole health approach and understanding what does matter to the patients that we care for, I think their responses will inform our approach to access and also impact our health outcomes in a much more positive way. So this does not just include access to illness care, but in whole health, we emphasize access to wellness care. And so it's important that the health and well-being of our patients is taken into consideration, including preventive care, and that very important category of self-care, which there are so many aspects that are within the hands of our patients to change, but we don't necessarily always give them education and support around health, self-care, so that their emotional and mental and social and environmental and et cetera needs can be met that greatly impact their health. And that is support around those behaviors that need to be changed in order to drive forward better health outcomes. So I see that we do have a challenge before us, and I don't see the approach to access being narrow. I see it being much wider than we might conventionally think about. And so I think it's important that we become intentional about having an expanded approach to access that is values-driven from our patients rather than system-driven. And I also think that we have to remain nimble and flexible, and we have to be comfortable with the messy and be comfortable coloring outside the lines of our conventional approaches. And I think that certainly in the VHA system, we are well prepared to be able to take this different approach so that our access to care is improved. Thank you.
Thank you, Pamela. I'd like to turn it over to Tia.
Hi, I'm Tia Archambault. I have been with the Department of Veterans Affairs for 15 years in various roles, most recently as their scheduling auditor. My background is in scheduling and can you hear me? Can you hear me?
I can hear you.
Oh.
Hi, Tia. We can hear you.
Okay, good. I'll keep going then. Thank you. My background is in scheduling and in VA software specialist. So knowing and understanding the functions and how to troubleshoot issues with VA software. So I have an extensive background, but I am here today to give the perspective of the scheduling in terms of access and wait times. And the discussion so far has been really enlightening, and a lot of my views are shared by others in the organization and in the private sector, and that's really encouraging. I do think, access is very objective and is driven by perspective. And I think that oftentimes in the VA, we try to make it more objective, and we really like to, quantify things and put data to things. And for access, it's more of a personal experience than it is a number. And so while it's important to try to improve always in our access and our wait times, trying to pigeonhole access into a number and make that a measure, something that we can measure, is I feel a little bit of a disservice to our organization. And I would say if we spent a little bit more time, trying to make it a qualitative approach to access and wait times, we would probably benefit ourselves better. As far as scheduling goes, the main issue, with wait times and access is obviously The amount of providers that the VA has, everyone, even in the private sector, experiences a shortage of providers. But our scheduling system is set up in such a way that it makes it really hard for our schedulers to find availability for providers that we currently have. So what I mean by that is our providers can have anywhere from 1 to 25 clinics that they see patients in based on the different types of clinic needs. And so, trying to schedule across those different clinics when the clinic appointment times don't, alternate, they tend to be a really rigid schedule. So, 8 to 4:30, they may see patients in their face-to-face clinic, and then they have that same availability in a phone clinic or a virtual clinic. And so for the scheduler, having to go into each of those different clinic types and block off schedules, you run into issues with scheduling conflicts a lot, resulting in a lot of overbooks, which increases patient wait times when they're in the facility. Not necessarily wait time to get an appointment, but wait time while they're there. So, wait time is not just, someone else said this as well, it's not just waiting for an appointment, but it's your experience once you're in the medical center. So both of those are really important aspects. And I really liked yesterday in the discussion, they talked about the use of the e-consult more frequently to create a collaboration of care between the primary care providers and the specialists. And that is an issue that we see a lot in VA is the primary care provider will put in a consult for a patient to be seen in, let's say, GI. And it might be for a month from now. And then the GI provider receives that consult, they review it, and they may determine that that patient could actually wait to be seen for 3 months. And so those wait times are calculated based on the date that the referring provider put into the consult, and not what the receiving provider, who's actually going to be providing the care, recommends. And so there's some disparity there. And I think that if they used more of the e-consult approach before putting in a formal consult, that would help tremendously with, the way that we calculate wait times, but also the veteran's perception of how long they have to wait. I also wanted to mention that, access in rural areas. I am in Missouri, and so we're in the Midwest. We have a lot of rural areas in our catchment area, and the access, not just for face-to-face visits for specialists or primary care physicians, but even the virtual realm, access to internet. Internet is hard to come by in a lot of areas in our catchment area. And I know a lot of other facilities experience this same issue. And we do try at the VA to provide alternatives for our veterans and are doing some great things with that. But, really expanding care to those rural areas where some of our most vulnerable population are is something I think that really we should focus on heavily. And, we are going to be getting Cerner, which will fix some of our
It looks like Tia is showing us what happens with rural connections. And so we'll come back to you, Tia, in a moment.
Yes.
And at this point, let's go to Peter for your opening remarks.
So my name is Peter Choi. I am the group practice manager in VISN 19, which is the Rocky Mountain Network. Our network covers Colorado, Montana, Utah, Wyoming, and Oklahoma. I've been in this position for almost 18 months. And prior to that, I was a group practice manager at VA Central Iowa in Des Moines. I just want to talk a little bit about the role of the group practice manager. So we have at least one at each facility, and usually one at the network level, which is what I am, a network GPM. And the role of the group practice manager is to have oversight of outpatient access to care at the VA healthcare system. So every facility has someone like me or that focuses on comprehensive management of all the factors that impact access to care. So this could include clinic schedules, scheduling process, care coordination, how we manage our referrals and consults, what are our space limitations and what are some of our staffing limitations. So we kind of eat, live, and breathe access all the time, and we look at anything that impacts access to care for our veterans. And so I just want to say thanks for being invited by the VA and National Academies. Like I mentioned, there are many different group practice managers within this country. So to be able to represent that group is an honor on this panel. So in regards to access within the VA, in my opinion, one of the fundamental challenges with the VA is that it's often difficult for our local facilities to respond to changes in our markets. And so one of the main concepts that they've talked about over the last 2 days is how good access is the result of balancing supply and demand. However, in the VA, we often aren't able to modify our supply to match the demand, in part because we don't have a very flexible system. And we oftentimes lack the resources in those areas to really match that demand. So first of all, we'll never be able to provide, to match the entire demand for all of our veterans, which is why we have community care. That's not going away. We're never going to be able to provide every specialty to every veteran throughout the country through our own VA system. But there are certain areas where, we are not able to be flexible enough to match the demand of our veterans that want VA care. So for example, we have a very large outpatient center just south of Denver, which was built several years ago. But during that time, the veteran population there exploded and without anybody knowing. And what ended up happening is because of the way that you construct facilities in the federal government, you start the planning process years back. And if things change during that time, it's very hard to shift course. And so what ended up happening is, we only had about half the space to match the demand of that local region. And in order to kind of increase the space and number of providers, it takes a lot of time to grow that through all the regulations and red tape that's involved in the federal government. And so as a result, we have to, kind of find lease spaces, different ways to get care to these veterans that really want to come to the VA, but we just don't have the space and the manpower to do it. And I think this is very common throughout the VA, either because of space challenges, because of rurality, where we can't hire certain specialties. Perhaps the demand isn't there in some of our rural areas that, it doesn't make sense to build a large facility there, and instead we farm that out to the community. And so, part of the issue, the fundamental issue with VA is that we aren't able to dial up or dial down our supply in order to really serve all our veterans that do want VA care. And so with this challenge, the way that we improve access is by maximizing the use of our resources and looking at ways to increase efficiency. And in a way, I think this is a really good thing, because as a result of having limited resources and not being able to procure some of the space and providers or staff that are needed to provide care, we have to be more efficient. And so, as a result, VA is very data-driven, and we rely very heavily on continuous process improvement. And I think that's an important thing in healthcare, whether you have the resources or not, to always try to be as efficient as possible. And, I really have to commend Dr. Kirsch and her team at OVAC for some of the recent initiatives to increase our efficiency. So looking at provider time, making sure that they have enough bookable time so that we're really maximizing the use of our resources, improving our communications for consult coordination with our veterans, making sure they understand what are their options for care so that they can make the most informed decision, and that way we can kind of shape our demand. And also in collaboration with the Office of Connected Care, really making a huge push for telehealth, which obviously helps to reach some of our rural veterans. It helps to share our resources. That is, we don't have this resource in one area, but we can share that with you through telehealth to another area. And I think VA as a whole is oftentimes thinking of ways, how can we operate better with limited resources? And so I strongly feel that, in order to improve our access, we need to continue to be innovative and create initiatives or process changes that help to reach veterans and provide the right care at the right time. Obviously, we are very metric driven, and I agree with everyone that said, access is not just about a number, but as we monitor those metrics and we try to improve on that, at the same time, I think that leads to quality in access as well. Not only getting them their care sooner, but making sure that they can get the right care, and achieving that through innovations such as telehealth, e-consults, phone care, and sharing our resources across networks or facilities so that we can better reach our veterans that don't have physical or geospatial access to care. So,
thank you, Peter. Appreciate that. Alexis, you're up next. Looking forward to hearing your perspective.
Hi there. I really appreciate the Planning Committee reaching out to the House Veterans Affairs Committee and including us in this discussion. It's been a really informative workshop and gives us a lot to think about as we craft policies that are intended to preserve and improve veterans' access to care. I've been with the committee for a little over a year, but prior to that, I worked for the U.S. Government Accountability Office, where I led a number of evaluations related to veterans' access to care at VA and in the community. And so I've visited a lot of VA facilities, I've interviewed a lot of VA employees, and spent hours and hours auditing VA consults and community care claims to examine veterans' access to care. And I think in some ways, VA has really come a long way from where we were in 2014 when the Phoenix wait time crisis captured national attention. But at the same time, the committee continues to hear from veterans that are experiencing various barriers to accessing care at VA and in the community. And of course, the ongoing pandemic just adds new layers of complexity to these issues and for veterans that need care and for the VA medical facilities that are responsible for delivering it. So it's clear there's still more work to be done. VA has undertaken a lot of initiatives since 2014, as Dr. Choi just mentioned, that have been aimed at improving access, things like vet text and same-day services, which Dr. Kirsch mentioned yesterday. And the rapid increase in the delivery of care through telehealth over the last several months since the COVID-19 pandemic started is also laudable. However, it's unclear how effective each of these initiatives has been in improving veterans' access to care, because VA doesn't always measure the effectiveness of key initiatives, or the data that it does collect and report are sometimes incomplete or unreliable. So as care delivery continues to evolve and the healthcare market changes as a result of the ongoing public health emergency, it's more important than ever to establish ongoing evaluation and monitoring of veterans' access to care. I think from the committee's perspective, the most important priority for us is for VA to empower veterans to make informed choices about where they receive care. And VA should be as transparent as possible and publish facility level data that will allow veterans to make apples to apples comparisons between access to care at VA and in the community. And that's not limited to just wait times, but also other dimensions of access and other metrics for access, such as patient satisfaction. So I think with that, I'll just, try not to make my comments too long. I'm just, again, grateful that VA and the National Academies have convened this workshop, and I look forward to continuing the discussion with the workshop participants and other stakeholders.
Thank you, Alexis. We'll come back to you soon. And last but not least, Emily, we'd like to hear from you.
Thank you. Well, hello. Thank you to the National Academies for having me today. I am Emily Blair. I serve as a professional staff member on the Senate Veterans Affairs Committee, majority staff for Chairman Jerry Moran of Kansas. So my portfolio of issues for the committee includes mental health and suicide prevention, telehealth, rural health, and medical research and development. So many of my comments here today will be around access to care, and patient-centered care will be within those portfolio of issues specifically in mind. I will begin by saying that it is obvious any conversation around increasing veteran patient access to care in the time of COVID-19 or a post-COVID world, must include telehealth or VA Video Connect. Well, VA has made great improvements and some adaptations to meet veteran access needs to meet increased demand. However, since the beginning of the COVID-19 crisis, Senator Moran and the committee have been concerned about the negative impact social isolation would have on the mental health of veterans and all Americans during this time. We were incredibly concerned about veterans who reside in rural and highly rural areas, medically underserved areas, and locations with limited connectivity and their ability to access care during this period and beyond. Because of that concern, Senator Moran led an effort in the CARES Act, or COVID Phase 3 package, as we know it, to give VA the authority to bolster the department's efforts around telehealth and VA Video Connect through agreements between VA and telecommunications carriers to connect veterans with limited or in some case no connectivity to connect them to the care that they need, with a special emphasis on mental health care. Well, VA really moved out in a positive direction. We saw providing veterans with tablets and iPads and looking at the connectivity piece on the VA provider side. It did take some time for us in Congress to work with the department on connecting the actual veterans in need of care, and something we still continue, to remain working closely with VA central office on. It's incumbent upon VA, Congress, and all relevant stakeholders, and I cannot emphasize and underscore this point enough, that in this technological age and moving forward post-COVID, that we do not leave rural veterans behind. According to VA's Office of Rural Health, a little over a quarter of Americans' veterans reside in rural, highly rural, and frontier areas of the country, in addition to our veterans in tribal areas where many of VA's telehealth efforts currently do not work that well or exist at all, unfortunately. This will be integral to ensuring all veterans have the equal access to care that they deserve, which continues to be the committee's goal. And the committee stands ready to work with VA to meet this unique challenge. Now I want to pivot a little bit to discuss the importance of patient-centered care, specifically in regards to high-quality mental health care and suicide prevention services. At the top of my remarks, I mentioned my work in the mental health and suicide prevention field, where on the policy side, I've worked in this specific area of veterans policy for a little over 10 years. I believe mental health care specifically is a crucial part of care for veteran and all individuals where patient-centered care is key. Obviously how a clinician engages with the veteran patient, the veteran and family's involvement in care, and the military cultural competency aspect are all incredibly important on the quality of care that is received and the compliance to the course of treatment. So while VA has made strides around improving mental health care and suicide prevention services, the Senate Veterans Affairs Committee believes more assistance is needed to combat veteran suicide. This is not a criticism on VA. We all realize and understand how incredibly difficult and dynamic combating suicide is, specifically in regards to veterans. However, that's why we on the Senate Veterans Affairs Committee have been working hard for the past 18 months plus on a piece of legislation, S785, the Commander John Scott Hannon Veterans Mental Health Care Improvement Act. This comprehensive bill has many different elements that will move the needle forward, but most importantly, will put the veteran at the center of his or her care. With that, I will conclude my initial comments and I look forward to any questions.
Thank you so much, Emily. Throughout our workshop, we've heard about the many ways to measure access, some observational approaches, and very importantly, the experience of access for veterans themselves. I'm going to ask each panelist to, given the context of this workshop and given the context of our world at this time, think about and suggest one or two of the most important things that the VA could do right now to improve the experience for veterans themselves, their experience of access. And Donald, I'm going to put you on the spot and ask you to respond first. If you could share with us your thoughts about, as of right now, if you had a magic wand, what could the VA do?
Sure, and I think I would first and foremost just like to highlight an initiative that we recently just featured that the VA took upon themselves, and they did it specifically through the Blind Rehabilitation Services. So as we're looking at specialized care at those pieces, and it was a personal touch. It was the fact that all staff diverted time to do one-on-one outreach with every veteran that was registered within that system, and again, we just kind of featured that because for me, as I sat here and we were managing, a now remote workforce, and there were those issues around isolation as we maintained our operations and trying to figure out what this new normal looked like for all of us, it was incredibly rewarding for me to get that call from my visual impairment services team coordinator out of Connecticut. I'm located here in the Northern Virginia, DC area. And it was really just that wellness check. How are you? What can we do? Are there any areas of concern right now? And so that was incredibly important for me. And we've heard tremendous feedback from our membership and folks just across the entire spectrum. And as we spoke with VA leadership on this, it's been rewarding on both sides. So finding kind of those unique ways to engage with one another, have that personal conversation, and really just that one-on-one. And they did take that holistic approach in that, did anything need to be done through primary care? Were there specialty care concerns? What could be done to help facilitate any of the unique needs that we were experiencing? So while it's understandable that it would be a daunting and overwhelming challenge for VA to have that level of care, and this is just one cohort within the population enterprise-wide, it was extremely meaningful and just making sure that they were ensuring that all of our needs were met, both on the physical, the mental, and just overall well-being. So ability to just be able to engage at that level with a representative from the agency, and then that individual taking the lead and making sure that they were able to connect us with any of the other systems that we might need.
Thank you, Donald. It sounds like both the connection was important, but also that it was initiated by the VA to you and that you weren't waiting to be contacted.
Yes, ma'am.
Renee, would you share the top one or two things that you think could be done right away by the VA?
Donald did a great job. I'll echo that. It really comes down to that personal touch. It's so meaningful. And I think and I'd like to just go back to my earlier comments about how important communication is. It is that communication that is not transactional. That's something Adrian mentioned yesterday. I think VA at times, and as veteran service organizations and military service organizations like MOA and VA, we often get, communication is sometimes one directional, and it's like pushed down rather than having a relationship. So I think from VA's having more transparency in its communication, using veteran and military service organizations as partners. They've done that, but I think that especially during a crisis, through a pandemic or a crisis, it's even more important. Oftentimes, I think VA looks at technology and pushes things out via their websites and thinking that, okay, that's how veterans are going to consume it. But again, as many of the panelists indicate, that not everybody gets their information, technology, through sites or even have the connectivity to do that. So I think that the relationship comes from that communication, and it has to be at VA central office and across the VISNs and medical centers with partners in their communities. But it's also got to be, as I think Donald mentioned, we need, as veterans, we want to have that connection with our healthcare team, with our provider. And we don't want to always keep having to initiate that. We want to be able to have that provider reach out to us and check on us if we haven't had an appointment. You hear a lot of that, but I honestly have not heard a lot, even through the pandemic, from my own VA. I was really pleased to hear, I got a voice yesterday from one of the leadership at VA Central Office, to let them know that we care and that VA's there. And, that was nice, but I don't hear it from my own VA medical center. So communication, I can't overstate it enough. It's so critical. And that's where the relationship, because everything at the end of the day is local.
Thank you, Renee. Dr. LeDeaux, what do you think?
I think I didn't unmute. I think one thing that VA could accomplish right away is to do a comprehensive assessment of what veterans say their preferences and needs are around access to care. And I think that's, and if it's been done, I don't know, I haven't seen it, but I think that information might be very helpful, and then helping us decide what next steps might be. So that is, in terms of a magic wand, if I had a magic wand, more difficult things to change would be our support systems, because I think our scheduling system and our medical record system aren't as flexible as they could be around access. And also some of the, the ways we measure that access. If we could be much more flexible around those things, I think it would be helpful. So those are my two suggestions.
Thank you so much. Tia, we lost you at the end of your conversation last time, but you're back and we're glad to see you. Would you mind sharing the top one or two ideas you think that could be implemented soon for the VA?
So I completely agree with all the panelists who have gone before me. Communication is key, especially as we move forward into this new realm of providing telehealth and virtual care options for our veterans, communicating that with them and actually initiating contact with them to help them set up their test call in preparation for meeting with their provider. I think that would go a long way into helping improve satisfaction and to show that we care.
Thank you. Peter, what are your thoughts?
So I think if I had a true magic wand and I could fix something in a snap, it would be our scheduling system and the way that we coordinate care, not just the way that we schedule our appointments, but how we create that availability in our systems, in our grids, our clinic grids, is very laborious, and it's very hard to be flexible to meet the demands of veterans. This will be a long-term fix as we're moving towards Cerner, but certainly I wish there were ways that we could coordinate care for our veterans through the scheduling system in a much more easy or rapid fashion, and also across systems. If you're at one facility, you don't have access to the medical records or the electronic health record of another facility. And so we kind of operate as 140 different hospitals as opposed to one VA or even one region, where we can work together to share our resources and get the right care to the veterans. In regards to communication, though, I support what everyone has said, but sometimes I feel like it's the optimal communication that really makes the difference. So, for example, we reach out to our veterans in my opinion, just so many ways. We have a robotic phone call appointment reminder. We send them a vet text. They get a letter or a postcard. They can use VetLink, all of these different ways to figure out what their care they have. But at the end of the day, what we don't do well is providing a communication channel based on a veteran's preference of reaching their provider. I don't know how often we hear, I can't reach my provider. I go to this call center and I get lost in there. I would love to see that improve, because in my opinion, having that immediate access or easy access to just reach out to your provider or your team and get some information is something that we could improve very quickly, in my opinion. And I think it's a huge customer satisfier and truly is an easy path to access.
Thank you, Peter. I'm hearing a theme here around preferences being important. That's all the speakers have addressed so far. Alexis, would you like to comment?
Yeah, I just wanted to pick up on a couple of things that others have said already. Dr. Choi was just saying that, there's all these different ways that VA tries to reach veterans and remind them of appointments. And, there's texts and postcards and robocalls. And I think it's important for VA to start spending a little time focusing on finding ways to monitor veterans' satisfaction with their access to care on an ongoing basis, and do that in as close to real time as possible. I know that they have the SHEP surveys to monitor satisfaction, but my understanding is that those surveys are often sent out months after an encounter occurs, and that means there's a lag in the feedback loop. So that makes it more difficult for VA to take action to address issues that may have impeded veterans' access if they aren't hearing about the problems until months and months after the fact. So that's just something that might warrant some attention.
Thank you. Emily.
Sure. So I think, based on my earlier comments, I think one major reason, or one major way in a post-COVID world, would be working to improve connectivity for telehealth and VA Video Connect opportunities. So a lot of the veterans we've heard from, back in Chairman Moran's home state of Kansas, or in more rural areas of the country, even though the strictly speaking, the telehealth side has been working okay for them, they're not, able to really benefit on the VA Video Connect side. And that's, a more richer experience for the patient connection. The second thing I would mention, again, more mental health focused, is, though the VA has made strides recently on the primary care mental health integration initiatives, I personally would like to see more connection and integration between primary care and behavioral health care.
Thank you. Again, getting back to the whole person and all of their needs. My next question is targeted for Donald and Renee in particular. I'm really interested to know from you, what are your suggestions about how we get more of a veteran's voice in this, about their perceptions of access? How do you think we can go about that? Donald, do you want to start?
Sure, I'm happy to. And I think, a model that I draw upon, and I stress it as often as I can, I'm very fortunate to serve within the congressionally directed medical research programs on multiple panels. And I think the beauty of that program is the fact that you really have the consumer perspective. You know, we get together and we review research proposals, and we're able to really look at this independently. And then we convene in a panel deliberation, and you bring some of the world's greatest scientific minds together, and folks with all different types of subject matter expertise, whether it's bioethicists and other individuals. And we can look at a proposal, and it can be phenomenal. Some of the most incredible research imaginable. And then it's those of us from the consumer perspective sitting in the room that can say, it looks great on the bench. It makes a lot of sense in the lab, but this is why it's not going to work when you try to deploy this. And so I think going back to what Renee mentioned earlier, it's really the fact of creating those unique opportunities for VA central office to engage with us early on in the processes. You know, we look at what's happening right now with the electronic health record modernization and with Cerner. And one of the first things that I brought up in one of the town halls was, you know, what are we doing around the compliance issues? Not just for veterans on the outside dealing with visual impairments and sight loss, or, you know, folks that are dealing with any different types of challenges, but we have a lot of folks inside of VA that are employees that deal with this as well. And so what we tend to find out is it's always an afterthought, and then we're trying to figure out what the solutions are after we've deployed, rather than just allowing folks that understand these systems, you know, that voice in the beginning. So I think there's unique opportunities. I do see the Department of Veterans Affairs putting forth efforts and initiatives. But again, I think it's really and truly seeing how many stakeholders can come together to look at these options, again, before we put something out for a request for proposal. A couple of quick examples, you know, we've moved with technology as we look at automation within the centers themselves, at VA medical centers or community-based outpatient clinics, and whether it's a kiosk system that a person that's blind cannot access, or whether it's a pharmacy that goes to automation with a scrolling marquee that somebody can't see. Our organization, Blinded Veterans Association, has a great partnership with the Department of Veterans Affairs, as do our colleagues over at Paralyzed Veterans. We go out and we do care reviews at the blind rehabilitation centers. There's 13 inpatient BRCs, and then the Visor clinics, and we go out and do the reviews. It gives us an opportunity to meet with the entire VA medical center, from the director down. We do everything from going to the cafeterias to the pharmacies. And we're always, you know, fascinated to see that this technology's gone out, it's been deployed. And we ask a simple question: how would a blinded veteran know that their prescription has been filled? And what we find out from the pharmacy techs is, you know, oftentimes when it's a blind individual, we realize that they've been sitting there for about an hour and hadn't reacted. So we go out and ask them what they're waiting for. So it just, whereas if there was an audible cue that was incorporated in that, or simple approaches to these. So again, you know, we're going to circle right back into communication, allowing the stakeholders, those end users, and I'll close by saying, I think that the CDMRP program has set really a unique model on how that works so effectively, and the outcomes that we see and what we end up scoring as winning awards are a direct result of bringing all of those different stakeholder communities together.
Thank you, Donald. Renee, what are your thoughts about getting more input on veterans' perspectives?
I think just a couple other thoughts, and I'd like to, you know, piggyback on what Alexis was talking about, and where the veteran, I mean, where VA is actually getting more information from real-time information from the veterans and their experience. I mean, it really does mean it's so meaningful to have that ability to engage with the veteran at the local level. And that information is not only collecting from the veteran, but even coming back to the veteran, even with some of the satisfaction surveys, that VA talks about and how it's improving. As a veteran, I'd like to know what that means to me. I mean, how can I translate that? Because maybe I'm not seeing it at my VA. And VA has done a great job in setting up veteran engagement boards around the country. So that's another local opportunity. Some work better than others. I think that veterans want to be engaged. They want to feel part of and being to improve the system. And so I think that oftentimes the veteran doesn't know how to engage with VA at the local level. And then, sometimes the VA is so busy with, outside of the pandemic and busy anyway. But I think coming together,
It looks like Renee is frozen at this moment.
a lot of these things.
Renee. You back? Okay. Let's move to another question, which I'd like to target towards Pamela, Tia, and Peter. And this is around the issue of flexibility and standardization. We're thinking of system design, and I would very much appreciate your thoughts about how do you incorporate veteran preferences, which are very much at the individual level, with your local context and the local kinds of needs for flexibility in different ways in the context of a national system and the need for standardization across. This is a very long question, a very complex question, but if you could just give some brief thoughts about how do we balance those different elements as we think about solutions. And Pamela, could I ask you to start, please?
Sure. I think that is a complex question, but I think the way I view it is that we do need local flexibility, because from veteran medical center from medical center to medical center, region to region, I do think there could be some common preferences, but there may be some regional preferences. So what is true here in New Jersey may not be true for what veterans want in Wyoming. So I think that we could standardize our process and our approach, but allow for the acknowledgement that there will be regional differences in the preferences. But I also think there will be some commonalities across all of our areas. So I think it's a matter of recognizing that the flexibility part of understanding veteran preference is okay, that they don't match entirely, but the system that we put in place allow for that difference to exist. So I know that's very non-specific, but I think it would be okay if we looked at it that way.
Yeah, thank you. Tia, what are your thoughts?
Okay, sorry. Can you hear me now?
Yes, please go ahead.
Okay, thank you. So I think the VA has gotten kind of a wake-up call in the pandemic in how they're able to, try to provide healthcare and different ways to provide healthcare during a pandemic. And as Pamela was saying, every VA and every VA population is different. And so it's really forced the VA, as we've all experienced various stages of bringing patients back into the facility to some extent, to provide that flexibility and really engaging our veterans and determining, what are their needs, giving them options in healthcare. Would you prefer to see your provider face to face, or would you like a virtual visit? What's more comfortable for the veteran at this time?
Thank you. Peter, your thoughts on flexibility and balancing this system design issue?
So I think it's important at every facility throughout our country to do a better job of listening to what the veteran wants based on their local, what's available locally, and then also making sure that they understand all of their options and offering that. So, some standardized scripting or even a way that we capture that in our electronic health record would be very useful. But I think more importantly, when you're thinking about the local needs, obviously someone that lives in New York City is going to be very different than someone that lives in rural Montana. And, that modality of care, as Tia was kind of alluding to, and our flexibility that's arisen from this COVID crisis, we need to capitalize on that. We need to make sure that our rural veterans understand all their possible options in care, letting them know that, hey, we could hook you up with a rheumatologist in Salt Lake City, or maybe we're just going to do an e-consult and I'll call you back with your results, and making sure that they understand all of the different ways that they can receive that care. And then from the VA side, it's important that from the clinical standpoint and from the provider standpoint or the care team standpoint, that they're willing to do those things, that we have in the background all of those pathways kind of set up so that we can deliver on what we're offering, in a seamless fashion, so that veterans, at a more rural site feel that they have those options for care as well, and that they can easily get them. Making sure that we communicate that and also delivering that, I think, is part of having a more systematic or nationwide or region-wide type of access to care.
Thank you, Peter. I'm going to toss my last question to Emily and to Alexis. This is related to a response to the pandemic. And there have been a lot of changes in healthcare delivery and access, as we've heard in the workshop, in different ways. What do you think in the long run will be sustainable in terms of these changes, and what are their implications for access? And Alexis, would you mind starting?
Oh boy, I was hoping Emily would go first.
Emily, if you're ready, you're welcome to.
I mean, I think that, it's very heartening to see how quickly VA was able to ramp up the delivery of care through telehealth, and we hope that that will be sustained. It's also been great to see the rapid hiring of new employees, and we hope that those new hires will stay on and continue working at VA after the crisis has passed. I think it's incredible how quickly they've been able to get staff on board, and I think there have been some sort of temporary flexibilities allowed for hiring processes, and so maybe in the long term we can look at more long-term fixes for those hiring processes, so that it to onboard employees moving forward. I don't know. Do you have anything to add, Emily?
And now, Alexis, I would really agree, especially on the workforce side of things. The way the department quickly ramped up and, kind of breezed through a lot of the hiring issues that we had previously faced in the department is something that I know we all are wanting the department to continue on. And I know the Senate Veterans Affairs Committee is very interested in continuing to, work with our House colleagues and with the VA in order to make sure those are permanent. As you all know, pre-COVID, there was significant barriers to hiring from anyone, from, the most basic, frontline healthcare employee all the way up to a psychiatrist. And I think, continuing to move beyond those barriers. And I think, I will very much compliment the department in that way, to where they were able to kind of, really meet and exceed that challenge. I think from my point of view, on the telehealth front, little concerned about, obviously the access to care and the connectivity piece there that I've talked about before. So, I think it's going to be incumbent on, folks like myself and Alexis and our colleagues in the House and Senate to continue to just tell VA, how can we be there? How can we work with you legislatively to meet those connectivity challenge for our rural veterans, for our tribal veterans in frontier areas, and so on and so forth. But I really think, the VA, especially on the workforce side, has been able to really quickly meet that challenge. And we would like to see those changes continue.
Yeah, I mean, just going back to telehealth, just one other thought to add, it's, telehealth is not the panacea by any means, but it does, hold a lot of promise for helping reach veterans wherever they are. The House Veterans Affairs Subcommittee on Health and Technology Modernization had a joint hearing recently where, we examined telehealth, and, we had a whole panel, where we heard from various stakeholders about challenges in, rural communities and reaching, certain demographic segments of the veteran population that still will need to be addressed. I'm interested in continuing to work with VA and trying to get a better understanding of the extent, sort of the different modalities through which telehealth has been delivered during the pandemic. I still don't feel like I have a great understanding of how much of it has been telephone based, secure messaging, text messages, video connect. I'd like to better understand where we are and where are we trying to go? Like, what is the goal that we're trying to reach? Because I think it's, you're more likely to achieve progress if you actually have a goal and strive for it. So.
Well, thank you. This has been an incredibly rich panel, and I so appreciate all of your perspectives and your thoughts. I think you've added a great deal to the workshop overall. And obviously, these conversations are just beginning. There's a lot more to do from here. And I just want to, on behalf of the Planning Committee, thank all of you for your participation and for your rich engagement. And I'll turn it on back to Dr. Kaiser. Thank you.
Thank you, Heather. Really appreciate the great way that you've moderated this panel, and thank you to all the panelists. What I'm struck with after listening to the comments is more a beginning of a conversation, more the beginning of a dialogue that needs to occur than the conclusion of it. And there's so much here that seems like we really need to flesh it out. And particularly moving from kind of the high level general statements to the more specific. How do we actualize these things? How do we turn the good ideas into operational things that we can start working on Monday, if you will? So lots more, I think, that needs to occur.